This is the third provider breakfast that we've had, and we're so thankful to have 3 different organizations here to share information about mental health integration. And first of all, I just wanted to, I'm going to do the quick introduction, give their names, and I'm going to let them introduce themselves. They're going to come up here and we've given them a half hour each to present their information, and then we're asking that you save your questions until the end. So we should have at least 20 minutes at the end, hopefully a little bit more, where we'll be able to ask them questions and find out a little bit more about the programming. I've also talked to them to see if they're able to stay a little bit afterwards, and they are able to do that if you have some questions that you need to ask them afterwards. If there isn't time, they will be available afterwards. So what we're going to do, I'm just going to give the names. Megan Grasser is here from Behavioral Health. She's a behavioral health specialist with Ministry Behavioral Health. And then we have Dr. Gabby and Jonathan Blake, who are here from the Children's Hospital of Wisconsin. And then we have Beth Clay, who is here from the Fox Valley area. And again, I'm going to have them introduce themselves, but I did want to at least tell their names. And then before we get started, Kay Jewell from NAMI wanted to say a few words.
Thank you. Hello, good morning. Good morning. Great drive, right? We're all here. What I wanted to say is that the whole issue of integration of primary care and mental health is coming from a lot of different directions. For a lot of us, it's coming from our local need because we have a shortage of professionals, but there's also a lot of push at a national level to deal with the integration, also because there's a shortage at the national level. But also because of 2 issues. One is financial. It turns out that readmissions in the United States for schizophrenia and bipolar are in the top 5. So there's a lot of push all across all payers to reduce all readmissions. And of course, that means that they're really interested in doing better in mental health. So unfortunately, it's a financial reason to do better. But we'll take it. That's what we get a financial reason. The other reason is that there's a push to get more integrated healthcare systems. And Medicare wants to have everybody out of the fee-for-service into an integrated system within the next couple of years. Integrated systems also want to do better at how they're treating and caring for people so that they're using the least number of resources. And they're starting to realize that they're not doing very well with mental health. There's also the recognition now, how many years has it taken? Decades for people to realize that mental health affects physical health. And so now there's a lot more push when you look at heart attacks. They want to make sure the person's been evaluated for depression because it affects the recovery rate, also affects mortality rate for every single condition out there, physical condition. So there's also that interest. So there's the interest of integrating and getting more information about mental health to the primary care. From a quality perspective, it's important because people who commit suicide, 75% have had a contact with primary care, and less than 40% had contact with mental health. So it's another quality person reason that we want to have better integration with primary care. There's a reverse side to all of this integration also. People with mental health conditions have more physical health problems, and a lot of times those get avoided or not taken care of. They have like 10 years shorter lifespan, and not because of suicide, but because of things related, schizophrenia genetically has a higher predisposition to things like diabetes and heart disease. And so there's more of a push in terms of quality measures. Our clinics and our doctors are being measured on whether they're evaluating a person with schizophrenia to see if they have diabetes, or if they have a metabolic problem, or if their lipids are being taken care of. So there's that other side of integration. We're not going to talk about that part today, but it's also an important part. So today we're going to talk about the integration of mental health and primary care from a mental health perspective. which is a bigger challenge. It's easy in the same system, but because of our insurances now, sometimes our mental health is over here, and our primary care is over here, and then we have to try and integrate. And especially that happens when our mental health is outside, so it's not in the clinic system, which we have a lot of in Wood County. So, this is an exciting presentation. Thank you. Oh, also, CIP. We're setting up training to do what is called crisis intervention training for partners, which is anybody other than law enforcement, about recognition of mental health and also de-escalation skills. We'll be offering it in Portage and Wood County. There'll be some flyers in the back, and if people want to sign up to get notices. We're also starting to work on crisis intervention training for law officers, which also will be presented here in our local area. More information in the back. Thank you. Thank you.
My name is Megan Grasser. I'm a licensed professional counselor and a behavioral health specialist at Ministry Medical Group in Plover. And I also brought Alyssa here.
I'm Alyssa Stoltz, so I'm a licensed marriage and family therapist at Ministry Medical Group in Wapaka and the Hoover Road Clinic in Stevens Point.
So I'm passing.
What?
Do we need to talk louder? Okay. I'll try to do that. Let us know if you can't hear us. So our roles are really part of Ministry's patient-centered medical home, which started about 4 years ago. Ministry, the first handout that I'm sending out is on the patient-centered medical home. Ministry really wanted to focus on addressing the whole person when that person comes into primary care. So as part of that, they hired a variety of new roles into family practice and primary care. One of those is our role as behavioral health specialists, so licensed mental health professionals. They also hired nurse case managers and some other support staff to really be able to address that. So the behavioral health specialist role is really their way of trying to address a lot of the mental health issues that are coming up in primary care. Patients coming in who have some sort of mental health crisis, are looking for resources, and wanting to be able to address that right away in the clinic that day versus having to try to find the appropriate resources that the primary care provider may not be aware of and may take a longer amount of time to get them in to see someone. So we can kind of go into a little bit more detail of what we do, but there are behavioral health specialists located in all of the family practice clinics. So pediatrics, family practice, internal medicine in the central and northern region. So do you want to talk a little bit about some of the specific things we do?
Sure. Let's see. Oh, and kind of a side note about our role. In the primary care clinics, having the licensed therapist, we're there kind of for short-term support. So we're not doing diagnostic intakes or billing. So we're there so that there's not a barrier between somebody coming in crisis or just needing some support and getting some mental health support. So we're there for right then. So sometimes they pull us into an appointment. Sometimes they just schedule a patient with us, but we see them on a short-term basis. So it's kind of like getting their needs met, assessing at all times for what resources they may need, and sometimes referring them on to more ongoing, longer-term counseling. Kind of an average of how many times we see a patient is 1 to 3 times, just because we can kind of see them, say if it takes a month to get into therapy, we can see them until they get in, just to get through whatever they're dealing with. But the one caveat is we can't meet with patients who don't have primary care within Ministry Medical Group. So, it's not, if we see somebody scheduled on our schedule that says, oh, referral is coming, or waiting on insurance, then we know that they kind of have been mistaken, and that's not our role. So you don't need a referral. People who just have primary care within Ministry can just call their clinic and ask to get scheduled with us. So short-term counseling, we do crisis and suicide risk assessments. So again, we've helped work with patients to see if they need to get referred to go to the hospital or the emergency department to be evaluated, to then maybe go up to the 4th floor at St. Mike's to the mental health unit if they're feeling suicidal. So we work really a lot in collaboration with those nurse case managers and the primary care providers to make sure that the patients are getting their needs met. And it's not, I think part of the reason they wanted to get this going is it's not just giving them a business card and saying, here you go, call. We're making those appointments and we're making sure they follow through and following up. We also do follow-up calls when people get discharged from either the emergency department or inpatient unit for anything mental health or alcohol and drug related. Just to make sure, again, that they have their needs met, maybe follow through and see, hey, do they have any questions that we need to refer on to the nurses or the doctor, or do they need to get scheduled for primary care or counseling? Just seeing if I missed anything. We also help with smoking cessation counseling and explaining power of attorney for healthcare documents to patients, and just facilitating. We've all done training on facilitating that conversation for power of attorney and just opening up a dialogue. And we have the opportunity to spend more time with patients to talk about all of these topics than their primary care providers do. So rather than sort of pushing them off when they're sort of in crisis, they can send them to us right away. Do you want to maybe talk about screening?
All right, and then in collaboration with our roles, ministry has been trying to incorporate more mental health screenings into primary care. So if you've been to a ministry clinic lately, you've probably had a PHQ depression screen done while you were being roomed in the clinic. So a couple of years ago, they started to do annual depression screens for all patients 12 years and older coming into the clinic, just to address, is there something going on that maybe the patient isn't going to be bringing up to that provider otherwise. And if they're scoring high on the PHQ-2, they'll do the rest of the 7 additional questions. And based on that, develop a plan for how to address that. Is it referring them to one of our behavioral health specialists, referring them to psychiatry, counseling, connecting them with resources, and really addressing that. In addition to that, they also, one of the handouts that I passed around is a mental health screen. So a lot of our providers on a regular basis, for any patients who have depression, anxiety, they're going to be doing at every medication check a screen on how are their symptoms for depression, for anxiety, for PTSD. So being able to address that at each follow-up visit related to mental health, just to evaluate, is the medication working appropriately? Are they getting what they need out of counseling? And if things aren't improving, what can we do to improve that? What can we add to that service? In addition to that, the other handout that we passed around is the depression stoplight tool. And so that is through Suter. And the stoplight tool, they do that for a variety of diagnoses. So ministry had been using that for a lot of physical health issues, but more recently we started to use that as also a tool for depression. So it really gives a visual that patients can take this home and put it on their fridge or somewhere where they can refer to this, and it will show them, you know, if I'm feeling some of these symptoms, am I doing okay? Am I maybe doing a little worse than I'd like to and maybe I should contact someone? Or is this something where my symptoms are pretty severe and I should reach out to get some immediate services? So on those, we do put labels with contact information for primary care and counseling, as well as 911 and the emergency crisis line. So those patients have those numbers there that they know they can find those easily and reach out when they need help. And on the back side of that, the provider or medical staff or behavioral health specialists can go through that backside and create an individualized plan for that patient in terms of what would be beneficial for them to improve their mental health and what might be helpful when they are starting to feel like they're moving to the yellow or red categories.
In pediatrics, in Stevens Point, our behavioral health specialist there, she's a licensed marriage and family therapist as well, and so she's helping the providers do ADHD assessments by helping them complete the Vanderbilts with the patients. So that's just another assessment that they use in primary care, and sometimes she'll get a release and send it off to the school that the kid's at, and kind of be that bridge for the primary care provider. We're kind of that middleman who can get information to the primary care provider quickly and get it back to the patient without, the patient coming in to have an appointment and get billed for a visit from the doctor's office. So that's one of the things that the pediatrics department is doing.
And I'm just going to add a couple things that we weren't originally going to talk about, but it was kind of brought up when Kay was talking a little earlier, when she was talking about some of the financial issues and the readmissions into the hospital. Ministry also has a hospital readmission team that meets biweekly at St. Michael's Hospital. And so that's a team of hospitalists, hospital case managers, behavioral health specialists, nurse case managers, and the mental health unit, social worker, as well as hospice and home care. So every 2 weeks, we go over an updated list of the highest readmissions, so the patients who have been in the most within the last 2 months. So during that meeting, we really review what is causing this patient to be coming into the hospital and what can we do to prevent that. So ministry is really working as a team with all of our resources to determine if this is a mental health issue that they're continuing to come into the emergency room or be admitted to the mental health unit at ministry. What can we do as behavioral health specialists, primary care providers, to provide them support so that maybe we can help them address those issues before they become so severe that they're going into the hospital. The other piece that Kay had mentioned was cardiac rehab in Plover has a lot of patients who have had a heart attack, had heart issues, and are dealing with that depression. Cardiac rehab in Plover meets Monday, Wednesday, and Friday, and they developed programs where one piece of that is addressing the depression that comes along with that. I think a lot of times in the medical field that isn't always addressed in appointments. So cardiac rehab provides them that support where they have a specific group that talks about that it's common to have that depression following a heart attack. And a lot of times they will then refer those patients to one of the behavioral health specialists in the primary care clinics to help address those issues more specifically. In addition to that, most of our behavioral health specialists are involved in a lot of community-related mental health programs. So one of the programs that ministry runs in combination with NAMI is the mental health wellness groups in Stevens Point. They're held in the 2501 main building. And those are monthly meetings on a Monday evening that are community education programs aimed at any sort of mental health issues. And so those meetings are included in the NAMI newsletters. NAMI usually holds a meeting right after that happens. But those are run by a variety of people, behavioral health specialists, other counselors through ministry and outside agencies, but just as a free educational session for community members to go to. And then I'll let you talk about the suicide.
Also in Wapaka and Portage County, there's suicide prevention coalition teams. I'm on the one in Wapaka County, and we've been meeting for a little over 4 years. And so each year, both coalitions have speakers that we host, and usually they've almost always, I think, been free events, and sometimes people can get continuing education, but we try to bring in speakers on a variety of topics. The Portage County Coalition does a suicide awareness walk in September or May, I can't remember.
They've changed it. It's usually September. But
Okay, September, right? My coalition in Wapaka County is planning one for October. In conjunction, we're going to work with the Wisconsin Veterans Home to kind of do a collaborative one this year. So that's another thing that we're kind of working on, that just to get awareness out there and into the community about those topics. And then the Affinity.
yeah.
So just another informational thing. Affinity in Appleton is I don't know, we kind of own each other. We're
Sister company.
Yes, we're sister companies with Ministry under the same umbrella. They have similar roles to behavioral health specialists. They're, I think they're called care coordinators, but they do a similar thing with us. So part of their day is case management. Part of it is billing for therapy services. So the difference between our two clinics is we just don't bill for services, but we're doing similar things. So just to let you know, that is a role that's out there and kind of getting spread further and further. So is there anything else?
I think that's kind of an overview of basically what our roles are. Again, it's a free of cost service for any ministry patient, and we're there to be pulled in at any point if a patient is coming in and meeting with that primary care provider and having any questions or concerns about their mental health issues, whether it's dealing with the loss of a loved one or having a mental health crisis. We're able to be pulled in to that appointment right there on the spot, or if the patient prefers to follow up with them the next day or the next week. So Ministry has really been working hard to try to integrate those systems into the clinic to help address the fact that sometimes it does take a little bit longer for a patient to be able to establish with a long-term counselor and really address those needs. So I think that's basically everything we wanted to address. So if you have questions, we will address those after everyone is done here. Thank you.
Dr. Gabby and I are from the Child Psychiatry Consultation Program. So as introduced, we're part of the Children's Hospital of Wisconsin, we're part of the Medical College of Wisconsin. They're joined together, and now the DHS has also become a bigger part of what we do, but we do child psychiatry consultation with primary care doctors across a specific northern region of Wisconsin, and then down in the south, primarily in Milwaukee, and then a few surrounding counties. And so in one of the handouts, you can see that there is an actual map of the coverage area that we can provide consultation services for. So any of those primary care docs within that coverage area are able to enroll in our program and then receive a free consultation with 3 of our child psychiatrists that are on call. So again, as introduced, my name is Jonathan Blake. I'm the Northern Regional Clinical Coordinator.
I'm Gabriella Haji-Andreo, which is why I get called Gabby. And I joined this project after doing 12 years of direct practice child psychiatry for 3 counties up north, Marathon, Lincoln, and Langlade, and being completely snowballed under by the need. So I was in a different city every day, and no matter where I was, there was a long wait list and calls every day. I'm sorry I can't see you for X amount of time. So I started to look into other models to kind of spread the knowledge base to the people who are actually seeing the kids, and that would be the primary care providers. So maybe I'll just talk a little about the history. I told you I would just start talking and wouldn't shut up, but so basically it's about 2005 or 6, and I'd been at my direct practice job for a while and was just exhausted, you know, just bags under my eyes and never feeling like I could do enough, and started researching collaborative consultation programs. The oldest such program in the U.S., they started their pilot in 2001, and they officially launched in Massachusetts in about 2004 or 2005. So the oldest program of this type is not very old. And I started looking around my area, and Ministry Medical Group was interested in having a pilot of that model. So I worked for them from 2010 until 2014. And so in this kind of model, you don't take over treatment of kids, and I focus on kids or under, 19-year-olds basically. So the goals of collaborative consultation programs such as ours isn't to take over care. We don't have enough providers to do that in northern Wisconsin, central Wisconsin. Even in Milwaukee, they struggle with that. They've got, I think the wait list to actually lay eyes on a child psychiatrist in Milwaukee County is 10 months right now. And they've got like 3 pages of child psychs in the phone book. So the need up here, we feel like a bridge to nowhere, because there's 2 or 3 child psychiatrists who still have, at least a list you can get on. And Dr. Saul, I don't know if she's here. I saw her name.
We're all here.
You're all, there you are. Oh, she's not there. But anyway, so she is in private practice, and she's the only one in the 15 counties up here that we cover that you don't have to be inside Ministry Medical Group or inside Marshfield Clinic or inside Aspirus Clinic to access Dr. Saul. And I imagine she's super busy all the time.
She is.
And
Caseload is actually closed right now as well.
okay, so I know over the years, Dr. Saul has had to say, I gotta go home sometime, so it's really desperate up here, and models like this work with primary care to try to help them out in real time. So like right now I'm on call, I might get a call and have to go dashing, to take the call. But we take calls in real time, Monday through Friday, 5 a.m. No, not 5 a.m. 8 to 5. There's one of the 3 of us child psychiatrists are on the phone, and the other 2 are based in Milwaukee. And then I cover, when my 2.5 days a week I cover up here. So in real time, we'll provide whatever consultation we can do indirectly by phone. And doctors, so it's MDs, DOs, NPs, and PAs can call. Anyone that's primary care, it doesn't matter what medical organization they're attached to, so long as they're in our 15 counties, which you've got the map now. And we only cover a certain region because we are covered by a state grant, and most programs, probably about 25 of the 50 states in the U.S. now have a program, a baby program, and ours is actually almost a toddler, so we've been at it for about a year, but the other states don't have a collaborative program at all. But our goal is to provide real-time consultation on the phone or email, fax, however they want to get a hold of us. We want to further their education base to their comfort level. So we do educational talks. We've got a website where we've produced educational modules that people can access on their own time that cover basic topics like ADHD, anxiety, depression, suicide assessment, using rating scales, and I think trauma-informed care.
And so we also go around, not just that it's on a website, but that's part of the program as well, as we do educational series. And so we'll go into each clinic that gets enrolled and present on whatever educational needs they have. Yeah. If they don't know what they need, then we just start presenting to them. And so kind of like Gabby was saying, this started off as just being a grant. And so you can look at the map and you see how there's a little kind of coverage area in Milwaukee. And so in the beginning, when Kay was talking and talked about how there's such a lack of mental health care services, this is where the idea of it's easier to reach out to everybody than to a smaller group of people. And that's how the consultation program kind of got developed. One of our leaders, as a doc and his wife were talking, and she, as a primary care doc, would talk to him at dinner table and say,
he's a shrink, so.
And say, I have this issue and it keeps coming in and I don't know what to do. And so the 2 of them had talked about, well, let's jump on this Kubley family who originally started the program. They had a son who I believe had committed suicide because of mental illness and wasn't able to get the health care they needed, and they were able to fund a good chunk of money and start the program in a small area in Milwaukee. So then the medical college, as part of one of our leaders, the Children's Hospital said, well, why don't we match what you're doing and start this program up, which was kind of where Dr. Gabby was up here, and with ministry having the same little program. And so they reached out to her and said, let's try to grow this and expand it. So then why they decided the northern region and that exact 15 counties was just kind of, I think, all by chance. Gabby was up here. They knew that it was kind of a very desolate area of a high need. So we started then trying up this program in which we got grant funded to start a program. Our fund was covered really for one region, but now we're covering two with the amount that they funded us with.
We were underfunded. Imagine that.
So that was another issue with money in the state and trying to be able to really afford that service. But the idea now is that we're trying to expand across the entire state of Wisconsin, like a lot of the other programs that are already in place. And so trying to figure out how to do that, the state has now jumped on and is working with trying to expand and grow. We're limited to only doing consultation with primary care docs. We're not allowed to do face-to-face, yes, with consumers, which is tough. But then it goes back to, again, if we're doing face-to-face, then we're only reaching out to a small population. By doing consultation with docs, we can reach out to everybody, and at least there's something, and we're not limiting everybody then.
And these type programs are designed to meet the needs, or to help primary care meet the needs of mild to moderate mental illness in kids. And in Milwaukee, the kids that are severely ill that use our program are put on a wait list for direct care, because obviously, you know, if you've got severe illness, you deserve specialty or subspecialty care. It's not the patient's fault that there isn't any. So in Milwaukee, the program, the majority of calls are about kids with mild to moderate difficulties, and we serve as a bridge while they're on the wait list to get into direct child psychiatry care. Up here, you all that work here, it's hard to know what's the difference between moderate and severe. You know, when it's big time in your office, it's severe, you know, basically. So it's not that we turn those calls away, it's just that the program, it's hard to think of a subspecialty medical practice that could meet everybody's needs indirectly, and that's what the grant does not cover yet, is a face-to-face consultation where I could see them. And then that's the only time I could actually make a diagnosis and direct treatment recommendations. Otherwise, indirectly, it's a curbside consult where I'm gathering information, and I'm offering, you know, diagnostic considerations. You know, well, it sounds like maybe, you know, you should consider a diagnosis of some type of anxiety. Maybe you could do this rating scale to try to factor out what flavor of anxiety, and you could consider this type of psychotherapy or this type of medication, but it's all indirect because the primary care provider remains in control with the family of what actually comes of the consultation. Because obviously we don't tell primary care what to do, and primary care doesn't tell the family what to do either. It's just a way so that primary care can have access to evidence-based mental health care in kids, and then be offering the full array to the availability of services that are in their locality. So I say cognitive behavior therapy a lot, and yet there aren't buckets of therapists doing that specific therapy. Now, we should get more, because that's where the evidence base lays for kids and adults, so that specific type of therapy. In the meantime, we're recommending, you know, if they've already called us and we've made recommendations, the primary care can certainly call us back, and they certainly do, especially up here, because we're kind of our bridge to nowhere. We can't even put them on Dr. Saul's list right now, although I'm sure we, you know, send them that way, but we cover up to the Michigan border, so obviously that's not going to be practical for a kid in Ashland to get, you know, to Marshfield. It wasn't even practical sometimes for a kid in Merrill to get to me in Wausau. So, you know, there are going to be, even if we had child psychiatrists all over, you know, there are going to be barriers to care at times. But this is supposed to address the barrier of knowledge base, because in primary care training, they still don't have much training in mental health care, wellness or illness.
Yeah, and we're actually going in right now and doing some educational trainings with residents. So it's, yeah.
Yeah, we enrolled the family practice residents for the UW family practice residency in Wausau. And we're reaching out to other states to ask how they do that, and it's not that common. So
Right.
we're kind of pioneers, you know, but even the oldest program is 11, 12 years old. So the goal, like I keep saying, is to provide direct support if we can, to kind of widen the educational base of the primary care provider to their comfort level. It's not to shove them through a residency or make them feel like they must put this person on 3 mood stabilizers, you know, like that kind of thing. But at least give them options. What are the reasonable next steps that might be, make sense, be, you know, reasonably safe, accessible, that's important.
So how do you enroll? That's always a big question. I know we're saving questions for the end, so I'll try to answer questions for you. Primarily, we seek out primary care providers, and we don't, small practices, large facilities, whatever it may be, and we try to invite ourselves in and talk to them about the program, how it works, how they enroll.
That it's free.
That it's free.
Yeah.
Basically what's all involved. And I think for a lot of times it's scary, and the hardest part is for us just to get in there and to talk to them about it, because a lot of things get political, I guess, and they think that we're maybe more and bigger than what we are, but as
They think it's like you sign on for free and then you get a bill every month or something, you know? So
Right,
there's
but-
some suspicion, but because we're grant funded, you know, through the state, I hope that suspicion goes away
Right.
pretty quickly.
Right. So there's no cost to it. Enrollment is really simple. At this point, we've even tried to make enrollment as easy as possible. So we try to come in and do a presentation and answer all the questions and make our primary care docs feel really comfortable. But if we're not able to go in, you can simply enroll online, complete an enrollment form. And the only reason we really do enrollments is to be able to track our providers that are enrolled, so we know what type of service that is being provided, and so we can show that we're actually a benefit to the community and to the kids and to the primary care docs, so we can grow and expand. We don't want to just be a temporary grant fund. We want to be continual and last a lifetime, and hopefully grow across the state.
So we gather feedback from the primary care, and when I worked for ministry, I tried to do this as well, knowing that it's a young program and anything could be improved, right? So I would try to ask, like, when you need a consult, is it there? And I would hear sometimes, like, by the time primary care sits down to their mountain of charts, sometimes it's 6 o'clock. Well, we close at 5, you know? So there's some things that we might be able to expand to meet their needs better, because it's really rare for me to get a call before noon. If I do, they're waiting, and right at 8 they call because they still have the question from last night. But part of our goal is to understand how busy and harried primary care practitioners are forced to be these days, and also for us to help Milwaukee understand that it's even more pressure up here, it seems, than these gigantic clinics in Children's Hospital where, you know, if one person leaves the area, there's 19 other docs to absorb the caseload. Up here, if there's 2 providers and one leaves the area, I want the other one on suicide watch, you know, pretty much. So for us to even find a time when the 3 docs in a clinic might be in the same place for 20 minutes to hear what our program is almost impossible up here sometimes. So that's why we will enroll on the phone or enroll by fax, or we just want to be there so that when there's a need, the primary care provider doesn't feel forced to ignore it or to feel like they might give scary advice or inadvisable advice. We want them to remember that they can call us. And we do cover Wood and Portage County. Marshfield Clinic proper has, well, a year ago they said, no, I think we're fine because they do have a child psychiatrist. But we're going to circle back around and ask because, you know, I'll ask Mary Hennessy again. You know, that's a lot. They probably have like 30 primary care providers there. And if she ever sleeps at night, I'm not sure how she would be able to take all their calls and things. So we want to be available, but our job is not to put any direct practice child psychiatrists out of business. Heaven's sakes, no, we want them to stay and to recruit their kids into the biz. And
right, we want to be support. We
move
want
up north. And
we want to be there to help primary docs feel comfortable and know that they have something they can fall to if they are out of options and out of ideas. And like Gabby was saying, we do close at 5, but email consultations come in all night long, all day long, over the weekends. So we aren't a crisis service in that at before 8 and after 5, there's nobody there to answer your calls and really be able to assist you. But we are really a continual care service because we do email consultations after hours that when it's on your mind, a doc can send it in before they forget about it. When you go to the website, and I think the link is on there too, you all can check it out. We do CME credits too, so we do continual education for our primary care docs. There's also links for resources. And so we've collaborated with the Regional Resource Center, the Mental Health Initiative, and being able to know all the resources that are in each of these counties. So instead of everybody always having to call places and find these resources, that's a big part of what I do as well. You can call me indirectly. My information's on the website, and ask for a specific resource that's in a specific region. So whether it's a therapy service or an outdoor program or whatever it may be, that's in addition to maybe the medication or the treatment that's been recommended by the psychiatrist.
Yeah, I should have mentioned that's a big part of what we hope to do too, is to link families to the available resources through their primary care provider. And we're trying, but we can't be sub-experts on 15 counties.
Right.
But that's kind of how these 15 were picked. It is a region where there is a resource coordinator, where it is that staff's job to ferret out whatever available services there are. So we partner with the Northern Resource Center, and if I don't know or you don't know, they get on the case and look into it. So all of this, we don't want it to be a silo of stuff going on, and we've been pretty welcomed. Well, Ministry already heard of this whole model, so they were right on board. And Marshfield Clinic had heard of it, and Aspirus is coming around, but they have a child psychiatrist in Wausau. So I think they feel like they don't quite have as big of a need.
So Gabby and I are committed to this full time, and so we want primary care docs to depend on us to do the thinking and the research and the finding. Same thing with behavioral health specialists, care coordinators, social workers, whatever it is in the system. You don't have the time, and you all are seeing clients all day long, every day, and we realize that. We want you to just send us the message or send us the need, and then we'll take the time and put in the efforts to find and do the research and best practice care, whatever that may be, and then get back to you. So all you have to do is then take that information, figure out what you want to do with it, and then share it with the families that are there. And so usually we ask our primary docs to talk to the families that they do consult with the service, just so they are aware of it, because more of what we do is also on, I know you mentioned PHQs before, is we teach how to use assessment schools, how to do screenings. And so not only are we trying to do that with the families when they're at the hospital, but realize there isn't always a lot of time. They don't want to always take that time to sit there and figure that all out. So we on the back end of it will try to work with the primary care docs and send that information to them at home. Have them complete it, send it back in. We'll either help score, assess what that all means.
Packets.
We'll rate it, yep, and then either share that information or just send it right back to the primary care doc that's in place.
So I don't know when we started, do you?
We got time.
We got some time.
We have 10 more minutes.
Oh, we do? Okay. Well, let's see. So far, it seems that this program is helpful. I get good feedback, and hopefully you do too. And I think having been in direct practice for so many years, that helps me remember how busy and harried you can be. And to be a good doctor, you really wish you could do this, literature search and find a perfect book for a 7-year-old who just had a baby brother and now he's all mad, or whatever. And I used to do that stuff nights and weekends, but to be able to do it for a good doctor who simply is going to get in trouble with their boss if they delay, if they take the extra, minutes in the appointment to do that. I'm happy to do that for them, and the patient-centered medical home is a great thing as well, because the doctors don't have to ignore things, because that's hard on them. You know, most doctors I ever met really want to be the good doctors they're trained to be, but the pressures of the business part of medicine are just a drumbeat that's just drowning out everything else sometimes. But it fills a great need, because they know what needs to be done, but they might not have the training to do it. They might not have the time to do it. So I think that these systems really do mesh together well, and we're working on trying to get it a little bit more like it was when it was a smaller system that I worked in.
A big part of what we do is a research program to be able to expand and to be able to make sure that we're really meeting the needs of our consumers. And so that's the only additional part that we have to the program. We don't ask our primary care providers really of much other than just to do satisfaction surveys to help us move forward and better our program. And with those satisfaction surveys, numbers in comparison or how much our providers that are enrolled feel confident in providing mental health care, making diagnosis, providing medications. Like you were looking at like 20% and 30%.
At baseline.
At baseline, right. And so now all of our numbers are up to really 90%, 100%, where they feel much more confident in being able to have a client come in. And I guess to back up, this really all started because we know that our mental health clients are going to our hospitals for their health care, because there's too much of a stigma either going to a mental health specialist, either from their family, people in the community, or they just don't understand it and they're afraid to. So we know they're going to the primary health care providers. We know that's going to be the first person they're seeing. They're going to go in for a toothache, or they're going to go in for a broken wrist or whatever it may be, and then a parent or a child says, oh, and by the way, every night my child has an aggressive outburst that I don't understand and don't know how to treat. What do I do? And so those a lot of times are the calls we may be getting. So when we say we're not a crisis, it just means that we're not 24/7, but we do expect there's going to be crisis problems that come in, and we want our primary care docs to call and say, Gabby, I have no idea what to do. Help, what do I do? And so she actually has a lot of these calls.
It's not like I always know exactly what to do. I mean, psychiatry is a gray science. You know, there's a set of reasonable options. It's not very often that there's one thing you must do. So I'm happy when they call and just say, I don't even know where to start, because on the phone I can help them see how I would think through it, and that can help them with the next person that's similar. And I do get feedback like that wow, you helped me back up, because I'm always saying, like, because they might call and say, this kid got kicked off the bus, what medicine should they have? And I was like, whoa, you know, we got a whole big chunk in the middle that we have to sort through first. So they're feeling pressure. And sometimes, often when I was in direct practice, a family would come in and say, the principal said don't bring them back till they're on something. And I would kind of tongue-in-cheek say, well, what did the principal suggest? You know, because did they diagnose things they're prescribing or wanting to? So I try to help the primary care understand that you do have to be a detective. You have a lot of things to factor in. As far as a medicine to solve everything, psychiatry doesn't have that, and never will, and probably never should. I mean, that'd be creepy, right? Soylent Green or something. I don't know what it would be. But that there are a whole range of other things we should be thinking about when a kid and family are in crisis. And so helping them understand that you've got limited time today, so let's kind of cover basic crisis stuff. Is anyone being abused? Is anyone suicidal, homicidal? Are they on a medicine that's toxic to them, or the dose is too high or whatever? That might be all we can get done today, but you can reschedule, and you could have them do these rating scales. And from what I've heard, it sounds like it'd be very reasonable to refer them to psychotherapy right now, but I don't know what to write on the form. Well, there are wait lists for almost every therapist as well, so you can add info as it comes in. Just to try to help them understand that the jump to medication is a jump most of the time. It's not the next step. And these programs originally, many of the state programs were funded by the Department of Social Services, when they realized or noticed that foster care kids and kids in out-of-home placements were on like twice as many psych meds as other kids. So they said, well, how fair is that? And why are they just getting drugged into oblivion? And we've got to, help, because when they analyzed who's prescribing, there aren't enough child psychiatrists for us to be doing all the bad prescribing or, like misinformed prescribing. So what it really turned out to be is that kids go into crisis, they might go into a psych hospital and actually see a psychiatrist who may or may not start a med, but hospital stays are so short that it's scary for anybody to peel off a med. And so you can see, then they get in the community, they're still not well, they're still having trouble, so meds get stacked. And it's really worrisome, in my experience now, for primary care to know when it's safe and reasonable to peel off medication. So I think I recommend peeling off as much as I ever recommend starting something up. But without that knowledge, I can respect that. It'd be like if they came in to me and they had 3 cardiac meds. I wouldn't just say, well, what's the oldest one? Let's get rid of it. With psych meds, I might, I can reason my way through that. If this one worked great, somebody wouldn't have stacked the other 2 on top. So it originally, our program's not funded that way. Ours is just open to whoever has a primary care provider in our region.
There are no limitations, so if you have to have callbacks, if a primary care doc wants to call 2 weeks later about the same client, that's fine. If they want to call 6 months and a year, it's a continual program, a continual service. So we have those. We also have one-time callers that call in about a child once and they don't call back. We're not at capacity, so there's not a limitation of how many primary care docs we can have enrolled. I know the Milwaukee region is trying to settle in to make sure that we're not overwhelmed with calls, but we're not even close to that right now. We could take a call probably every 15 minutes, and we're not at that at this point. So our capacity is growing and hopefully continuing to. We have probably about 150 primary care docs enrolled in the 15 counties up north. So with that said, there's so many more that could still be enrolled. And so we want to be able to continue that. I think we're looking at probably about 45 clinics. So some clinics have 1 provider, others have 15 or 20. But usually when we go in, we don't get all 20 primary care docs enrolled. We maybe get,
the ones that are there, some of them, because we do have a enrollment sheet that lists what we don't do. Like we don't take over prescriptions, we're not on call in the middle of the night and things like that. So some of them want to read that more carefully, which I think makes sense. And then they get so busy, it gets buried underneath stuff, so.
Right, so I guess from you all, if you're not a provider, but if you know of a provider who is in any of those counties, inform them about the program. We talk to our families to go to your primary care doc if you can't get anywhere else, and try to encourage them to enroll in the program. We don't want there to be a stigma with our primary care docs using the program. We want them to be able to know that they're doing themselves really a favor by being enrolled and having this support, saying that they're reaching out and utilizing every service that's available to provide the best quality of care that they can. So go to the website. If you want to help us grow and expand across the entire part of the state, right now we're just recommending that you go to state legislation and try to promote it and talk to the importance about child health care and mental health with children across Wisconsin, and we hope to be able to really be part of the entire state at some point.
Yeah. That's the goal. So we did have a stakeholder meeting in Chippewa Falls, just like we used to in this region 4 years ago. I think we started, because it takes a long time for the process to move forward and get funding and staff and things like that. So, but spread the word. Our program doesn't mean that you're calling to ask what med they need. You can call for that, but I wouldn't want people to not call because they're worried that they're going to get forced to over-medicate children. I mean, obviously, that's not what I want to do. I want to use all the rest of my training. I mean, medication is about 20% of a child psychiatrist's training. The rest of it is thinking about what else causes thoughts and behaviors in kids and what might help those, those things so that the whole family unit can get healthier.
We'll stay around and answer questions in the end, and then even after it's over, if you want any other handouts or if you want any other contact information, feel free to reach out to us.
Good morning, everybody. My name is Beth Clay, and I am the executive director of a collective impact organization called the Northeast Wisconsin Mental Health Connection. We are a membership organization, and we have members all the way from Theta Care and Affinity down to our domestic violence shelter, homeless shelter, anyone who's a stakeholder in the mental health system of care, which in our region we consider to be the entire community. And one of our projects or our initiatives is called the Mental Health Integration Project. So we've all found our way to some kind of solution for the problem of lack of access to psychiatry. And I want to share with you kind of what the solution that was generated in the Fox Valley. So the new Mental Health Connection was created in 2011. We had a Theta Care chat plunge, Community Health Action Team plunge, where stakeholders in the community got together to take a deep dive into understanding what the challenges were in mental health. Out of that, a steering committee was formed. We started looking at other communities that had created a community collaboration around mental health. That led us to Tarrant County, Texas, Fort Worth, Dallas area. They have a mental health connection there, and we were born out of that model. And by 2012, they had hired an executive director to sort of create something out of nothing. And what we used was the information that came out of an enormous mental health summit where stakeholders were brought together to try to figure out what are the areas where we need to make an impact. The ones that came out of there were a 24/7 crisis initiative, looking at what happens to people in the emergency department, what happens to those that have county services, just looking at all of that and trying to ameliorate the challenges that we had. We also created kind of a philosophical and training initiative called No Wrong Door, because we had people that were, people with untreated, undiagnosed mental illness that were at the food pantry. How could the food pantry help them get to mental health services? And everybody wanted to be part of that. And so that involves a lot of stigma-busting training for frontline staff and managers in all different kinds of organizations to help them be a door that doesn't close, or we don't do that here, let me hand you a card. We didn't want that to happen. We also had challenges where people were having to tell their story 35 times. And it was really re-traumatizing for people to have to do that everywhere that they went. And could we create some sort of case management technology that we could get people to the right service, the right place, the right intensity, the right specialization the first time they ask about it or someone notices that they need it. So that's what the No Wrong Door initiative does. We have a children's mental health initiative, and the steering committee that was around that are the ones that created Catalpa Mental Health Center, which is a new children's mental health center that was a collaboration between Theta, Affinity, and Children's, knowing that everybody was losing money on children's mental health and nobody was doing it well. And so they decided, well, let's at least get together and do it well if we're all going to lose. And it's just been a phenomenal coming together of resources and support and a place of access for our children. We have a zero suicide initiative that looks at bringing that philosophy to our mental health service providers, our schools, all the different stakeholders. And they're in the process right now of doing organizational assessments all across mental health and community-based agencies that are non-mental health agencies. And we host the Fox Valley Substance Abuse Coalition, which works on 4 pillars of substance abuse prevention, treatment, law enforcement. And then we have the Mental Health Integration Project, which I'm here to share with you today. And So again, this is how we were formed. We serve a really interesting territory right now. Our footprint right now is 3 counties, Outagamie, Calumet, and Winnebago, and that includes some larger cities. It also includes some small towns. We have rural and urban. The concerns that were brought up at that original 2011 Mental Health Summit were we had a lot of access challenges. We had people waiting, like you said, 10 months to get into care, even for crisis care. It was just we had to do something. We also had a lot of problem with access that we weren't sure whether we didn't have enough mental health providers or whether those mental health providers that we had weren't trained in the right specialties or we couldn't find specialty care. So we needed to do a lot of assessment around that to figure it out. Obviously, we had a serious shortage in pediatric psychiatry. It was also inadequate for adult psychiatry access. We knew there was a nationwide problem, and so it wasn't going to be that we had to come up with a local solution because it was not going to, we were not getting more psychiatrists. We had strong family medicine practices. They weren't really full scope, but we thought, maybe this is where we can make an impact. And family medicine was just being forced to do that, where they were often the gatekeeper or the first person to see somebody who was starting with mental health symptoms. And they came to the summit saying, we really don't know what to do. So a task force was formed around this initiative. The health systems were coming together saying, we can't do this alone. We know we have challenges. The community was aligning underneath the mental health connection, and this seemed like a really natural place for them to come for backbone support. And we decided to go directly to the people that needed the help to ask them what they wanted from us. So a steering committee of physicians did some phenomenal primary care physician structured interviews where we had a set of questions that we were asking to sort of get a sense of things, but we also took free-form information that they were providing to help us determine what to do. Our leadership steering group, it looks a little bit different now, but this is how we started out. So we had medical residency program that was on the committee. Affinity and Theta Care were there. Mark Rovick, who's our local child psychiatrist, who I feel the same way as what Dr. Gabby was saying. I wonder how this man lives under the weight of the tsunami of need. It's just unbearable. I can't imagine. And he really wanted to make an impact so that the kids that needed him could get to him, because the kids that didn't need him didn't end up there, and we had to figure out a way to do that. The leads from Affinity and Theta Care Behavioral Health are on this steering committee, and I sit on this committee as well too. We pick the topics and the venues and the speakers and those kinds of things and drive change. So what did we learn from those interviews? That most of them did not feel any sense of competence or confidence in working with mental health challenges. They didn't really know where to find counseling for the people that they felt might need it. There was universal concern regardless of the primary care provider, whether it was NP, PA, pediatrics, family medicine, and they felt like they had no line to psychiatry. They did not know how to access them or talk to them or anything. And everybody said, yes, if it's CME offered way for us to learn about this, we will be there. And we took a lot of their ideas about the content. What was it that they wanted to learn? What were the areas where they felt the most ineffective that we could help bring them some confidence and competence? Some of the things they shared was that they felt like they didn't have a pathway to talking to psychiatry. They didn't even know who the psychiatrists were. They felt like there was poor access to any kind of counseling services or other resources. They felt like their patients couldn't access psychiatry either, so they couldn't, neither could the patients. And they had really no familiarity with, when you case manage someone, there could be a whole array of challenges, food insecurity, homelessness, other things going on. And so they were not familiar, and no one that they had access to had familiarity with what other services were available. The kinds of things that they wanted to hear about was certainly treating younger children, the ones that serve across the lifespan. When you get into psychotropic medication in young children, they really had a lot of concern about that. Depression that just seemed to be kind of lifelong. Bipolar disorder, schizophrenia, certainly suicidal ideation. They just would dance around the topic, hoping nobody said yes. ADHD, managing medication over time. Algorithms for treatment and diagnosis and differential diagnosis, and just being able to be somebody knowing that they have 7 minutes. How can they appear to be listening and providing counsel when they have that kind of shortage, and could we help them with that? So I was looking this morning just to be sure that I had the right number for you, but we've had about 215 providers go through training. We do a series, but they can sign up for the entire series for a discounted fee, or they can just come to whichever ones are the ones they want to go to. We have a lot of family medicine residents going through, and also NP students. So we have moved down from treating those existing primary care providers to building it into the education of those folks that are coming up now and are going to be our next workforce, which has been a really interesting shift. They really want this education. We do online evaluations of every session. We do a pre-test and a post-test of those folks who've been through 5 or more of the 9 sessions to just sort of get a sense of where they started and where they're feeling now after having been through this. We also do an open-ended survey after session 7, asking them about topic areas for the next year, things that they would go more in depth, even if it was offered this current year, things like that. So the users are still driving the content for sure. Like I said, they don't have to attend all sessions, but many of them sign up for all of them. We use the outcomes from the surveys from session to session. So we're quality improving all the time and making sure we're meeting their needs. This shows you sort of some of the pre-test, post-tests from the first couple of years, where one was where they were very uncomfortable, very comfortable and feeling skilled, and 6 was very uncomfortable and lacking skills. So you can see we helped move them in a lot of different areas to a more comfortable place and feeling like they had the skills that they needed. And so this was what planning feedback looked like after session 7 in the last couple of years. We had a lot of people that attended all the sessions. They felt that they were very high quality. They all felt like they would recommend this to their colleagues. They would attend again if it was new material or more in depth. They felt like the psychiatrists being the teachers was really critical to the quality of what they were doing, and that it was useful in their practice for them. And we did provide time for colleagues to chat, which they found very, very helpful. You know, when you're working on billable hours, there is no time to talk to somebody else. So this was for them new and different. Some of the feedback that we've received over time, what they loved was the psychiatric content, the pieces that they didn't have that could be useful for them. Every session has didactic portion at the front, and then we do case studies at the end for all of them. And people from the audience can provide a case study, or they have some prepared that they can share, and everybody really, really appreciates that. They like the diversity of topics, so we mix in, you know, your general, one's depression, one's anxiety, with other special topics, things like geropsychiatry, you know, things that are a little bit different. And it's nice to have different speakers at each session because they are all really different in the way that they provide their content. Sometimes they get too detailed and people start to fall asleep. Sometimes it's too introductory and so they fall asleep. Timekeeping is always a challenge. Oh my God, we're going over in every session, which is so disrespectful. And so, you know, we're holding up cards and we're, you know, I review the PowerPoint to make sure they don't have too many slides, and still we have a lot of trouble with timekeeping. And then feeling like as we were learning, there was content in there that maybe wasn't relevant for them. And so, like I said, after each session, a speaker that we have, especially if we're planning on inviting them back, we give them that evaluation and have them change their presentation based on what was provided. So what did people want, or what did they say? They want anxiety disorders, bipolar, ADHD, depression, you know, all of the things that you would expect. They really wanted help with. And then we've had the opportunity, our April session is usually a special topic. And this year we're gonna be doing the ACE study, trauma and trauma-informed care, and what does that mean to primary care, which I think is going to be fantastic. Last year we did suicide assessment, and there's been lots of interest in when you're treating over the lifespan of LGBTQ, what are the special mental health considerations, trauma considerations, things like that. So what's next for us? We're at a place where we've seen a real shift that we're getting tons of students, not as many existing primary care doctors. Now, some of that is because they're receiving, you know, these opportunities are coming more than they used to, but we still feel like we may need to rethink the model. You know, we have them come for a 2-hour session. From 6 to 8, we include dinner. So they don't have to worry about that. They can just show up. But what we're learning is that that may not be the best delivery model because it's 2 hours out of their life, and we're not sure that they are willing to do that anymore. So during this summer, we do strategic planning. The sessions start in September and go through May, and then we have a period to strategic plan, and that's what we're going to be looking at this time. Is when and where do we offer these? Would they be, you know, should we go to clinics for lunch and learns? You know, we're willing to do anything. We just need to find what it is they want from us. There's also changes coming down, and, you know, how do we respond to those changes? So what Dr. Gabby was saying, oh no, it was the ministry folks, you know, if you don't have ministry primary care, you can't access the mental health. So some of that is happening in our region as well, which is changing things. So we may need to have to split out our training and do it within systems, which before it was really collaborative and bringing everybody together. That may change. And they're talking about, you know, maybe we just want to train our own. Okay. We can help with that too, but again, it's been really critical for us to go to the audience to ask them what they want, how they want it delivered, and so we'll probably do some structured interviewing again, and go back for the top-down buy-in to it. So this is really, we sort of see this as a two-way program. There needs to be top-down support for physicians and other primary care providers to take the time to do this and, you know, push within their system that the expectation is you're going to be handling the first-line mental health stuff that'll keep those folks here so that complexity can move up to psychiatry and there's access availability there. But it's also a grassroots movement. It's about consumers saying best practice is that I have a medical home where you can integrate my mental and health and physical health care, and I expect that from my system. So it's grassroots and top-down at the same time, and that's what makes it really powerful. So that's it for me. So I think we're going to probably move on to questions now.
Can you just clarify with everybody, what roles can collaborate with you, meaning, because we're the behavioral health specialists, and so I've checked in, and I can't be the one to talk specifically to Dr. Gabby.
Yeah, we were talking about this earlier. Before we actually started, we were talking about it. So we enroll our primary care docs, and they fill out a form, and then we follow up with them and give them the call number. So the call number is really private to just our primary care docs, because we can't let it be just a known call number, because then everybody in the community will be calling. You can't put it on billboards. It has to be kept really kind of private. Otherwise, we'll just be overwhelmed by calls, and it'll turn into a crisis line. So once the primary care doc gets enrolled, they're the only ones that can really call into the call line. Otherwise, the call center will reject them and kind of turn them away. But then, like myself, and then in the Milwaukee region, there's a clinical regional coordinator who can work with like behavioral health specialists, social workers, when they have a more specific need that the primary care doc doesn't have a time for, or they've only shared with their individuals. They can email me, they can call me, and then I'll pass on and kind of bypass the call center, and then make sure that whatever that need is still gets addressed by the psychiatrist that's on call. So we don't want to turn anybody away, but the program has gotten to where it's pretty official, and so if you're not on the approved list, they won't let you go through. But we don't want to not meet the need of whatever the services, yeah.
Our program up north added on to the pilot that had been started in Milwaukee County. And in Milwaukee County, as of yet, they've only enrolled pediatricians. So when I hired on a year ago, they said, well, just enroll all the pediatricians in these 15 counties, and we'll see what we get. And I said, well, that's about 7 people, outside of Marshfield Clinic. That's about 7 people. That's not the majority of who sees kids in primary care up here. So Jonathan and I are gently trying to help Milwaukee see that things really need to go different up here if we're going to do what the kids need. So part of that is the pediatricians sometimes in Milwaukee area often have therapists connected to their clinic, like Ministry has a few clinics that have some behavioral health right on site or with the direct access to them. And so they so far have had or seem to have less need to have their behavioral health specialists or case managers contact us. But when I worked for Ministry, that really was the way to help kids the most, because oftentimes you all know more details of the story, and the more details I have, the better indirect consult I can do, and the more I can help kind of sort through what might be a good next step for them. So up here, right away when I hired on, I said that it wouldn't make sense to just enroll pediatricians. And they're like, why not? And I said, well, because, so I think because they're a huge organization, change sounds kind of scary, and I just think they would feel overwhelmed if they thought they were going to suddenly enroll the family practice, nurse practitioners, and physician assistants in Milwaukee County. So the next phase that we've been chipping away since about June is that the primary care providers up here are often like 2 or 3 in a clinic and are running like chickens with their heads cut off, and so they're getting a bit of the story, but then especially in Ministry, they're lucky enough to have behavioral health specialists so that the information doesn't get lost or ignored. But then they're still kind of worried in Milwaukee, and I'm not picking on them. I don't understand a big system. I've never wanted to be, in this huge system that I'm kind of in now. But anyway, we tried to help them understand that it's not that I'm going to give medication advice to a behavioral health specialist. That's really their concern, is that it would be providing medical, kind of making somebody without a medical degree do medicine or something. I'm trying to help them understand, and Jonathan is doing a good job at this as well, that we need them so that the primary care can use our program. They don't have time to sit by a phone. It's really, really rare for me to get a call up here. I get more calls from the pediatricians, which just to me feels like they have a little more wiggle room, maybe. So we are presently working on a system whereby you all can call or contact Jonathan, or down south, Sarah, and that's how we'll get access. So we keep a database of people who are formally enrolled, and the first call or email, or the first call goes through triage in Milwaukee. So if you're not a primary care on the list, they're not going to let it through. But we want it to be a friendly, we want them to tell you how to get through, not just to say, oh, you can't use the program.
If you have somebody that you want to call on behalf of that's not enrolled, or if a primary care doc calls and that's not enrolled, I'll enroll them at that moment. I don't want to turn anybody away. If there's a need for a child, well, we'll get you enrolled as kind of time allows it, but let's address the need here first. The enrollment will come, and so the priority is always whatever the health care need or the mental health care need is of the child. So.
Cool. Yeah, so we're working on that, and even though it wasn't me, I apologize that some people were getting wow, they tried to access, and especially the people that work for ministry thought it would be exactly how it used to be, but now, it's a team, and these two programs are linked together, although the regions are so different that we don't have a whole lot in common with each other, but we're working on making access make sense.
Cool.
Any other questions? I did have a question for Beth. You had brought up about a plunge. Could you tell us a little bit more about that? I know a little bit about plunges, but I'm just wondering if our audience knows
Sure.
about plunges.
Absolutely. So, thank you. Through the continuous improvement movement of Theta Care, they created a community health action team, and actually Affinity Ministry sits on that as well. It's not Theta Care owned. It's a very community-based process that allows for the community to come and say, there's an issue at hand, we don't know, we don't understand the scope, we don't know what, but we want to understand the problems. And so they created plunges, and what they do basically is invite an interdisciplinary group of stakeholders, including people with that lived experience. They get on a bus and they go around the community to visit, the places where people go related to that. They have panels of speakers, and the kinds of plunges that have happened. So we did that mental health plunge. The one that's happening in the Appleton area right now is what is it like to be African American in the Fox Valley? Shocking plunge. We're attending a plunge in Wapaka at the end of the month. They're doing a trauma plunge. There have been plunges on chronic disease management, transportation crisis, any number of community problems. And there was a poverty plunge, a domestic violence plunge. Lots of things like that. And then what happens is that interdisciplinary group and the chat team talk about what action they might take after that. And there is funding that flows through chat. So there's sort of seed money to help whatever is going to move forward. And members of that group end up sort of on the steering committee, and then it sort of takes off from there. And so the mental health integration project of ours, the actual creation of the new mental health connection, and our No Wrong Door initiative were all had seed money through chat because those were areas that really showed up in the plunge. So Theta Care would be the place to contact if you want to talk about that or model it in your community in some way. They've been doing it so long now that it really is, they have a wonderful structure. They actually used to do 3 plunges a year. But then they started to go more deeply into the issues, and now they do 1 a year. So it's, a long wait if there's another issue going on, but it's a really helpful way to build community will around something, to bring to light things. In the domestic violence plunge, the thing that came to light was that every worker in domestic violence and anybody stakeholder who cared about domestic violence was a woman. And what was created out of that was a movement called Voices of Men, and that that women alone could not solve this problem. Where the heck are the men? And it is a phenomenal movement. You want to find out about a great grassroots opportunity to make change, and that was born out of chat. So it's a really creative approach to community health problems in a public health way of looking at a lot of the different social challenges.
Thank you for that information. I know I've been involved in a plunge, and my role is to engage the community, and those plunges are a great way for a community to come together and learn more information. You immerse yourself in that topic for the day, and very, very educational. And I had Marshfield Clinic had put on a plunge years ago around the topic of drug use. And I don't remember specifically what the drug was, but we had gone around the community. Very, very informative. Any other questions? Well, if there's no other questions, you get lucky today to get out a little bit early. I do want to go over some of the notes that we have, but first I want to just give our presenters driving all this way. But I did want to let you know that just quickly, Kay is handing out the information about the CIP trainings that are being offered. So we do have some things going on in the community that hopefully you can get involved in. Out on our little breakfast bar out there was information about a trauma-informed care series that will be going on starting already next month, starting on Thursday, February 11th. And we are so thankful that the Children's Hospital of Wisconsin has partnered with us to offer this series. And so we've got dates and times already set with the Children's Hospital of Wisconsin for the next, there's 5 months that they're doing. And then we have a cultural diversity training that we're hoping that ministry will assist us with providing, so we don't quite have a date yet on that. But if you could take that flyer, I think I've sent it out, but if you haven't gotten it, please do pick that up and try to attend. If you are unable to attend those, we are taping them. We've been working with River Cities Community Access. They are taping them. They will be available online. And so we're super excited to partner with them also on that trauma-informed care series. There's also a flyer on Paper Tigers, if you're not familiar with that. This is a movie that, again, we're looking at that trauma-informed care piece, the ACE study. And our first showing is today, 3:30 at Marshfield High School. And then we are having another showing on February 17th in Wisconsin Rapids. And I just did secure a date and time for Nakusa Schools. And I'm probably going to blank on it right now. It's at the end of February, Friday, February 26th. Okay, Megan's giving me the thumbs up. And 9:30. 9:30. So we'll be getting that information out to everyone. Again, that was a partnership with Children's Hospital of Wisconsin. So they've been an amazing partner for us, and thank you so much for that. There's information on a pre-QPR training that we have a team of people working together in Wood County to offer those trainings. So please pick up that flyer. If you would like to have a training within your organization, we would be happy to do that. We also have a resource guide that we partnered with Marshfield Clinic to provide. This actually came out of our first provider breakfast that we had about a year ago. One of the requests is that when it comes to referrals, they weren't sure where to refer people all the time, that maybe if somebody comes to you, you're not the perfect person to provide that service for them. And so where do we send people? Where do we refer them? And so this guide has been in the making the last year, and it is continually being revised. And so if you can watch the Wood County Health Department's website, and then also the Marshfield Area Coalition for Youth website, you'll find the very most up-to-date copy on those locations This one was just updated on January 25th, so very up-to-date copy. Again, all that information is out there. We also do have a roadmap for services too that's out on the breakfast bar. So thank you everyone for coming out, and I look forward to talking to everyone in the future and working together with you on to solve some of these mental health and AODA issues that we're seeing.